to make this legal. Now, when it first became legal, there were a small number of people, physicians mostly, eventually some nurse practitioners, who agreed to participate. And I think all of them were living in real fear of doing it wrong and going to jail. It was complicated at first, and nobody really knew how to do it, how to do it safely. At the beginning, every single case was a coroner's case in Ontario, at least, and the coroner was had to be called after a MAiD case. You had to sit there with the deceased patient and wait for the coroner to call you back, review the case before they would actually release the body. So it was pretty intimidating, I would think, at the beginning. I don't think that there were a lot of people who were brave enough to do it. Gradually got better. Then the next step that made it to the Supreme Court was this patient in Quebec. His name was Alain Truchon. He had a neurodegenerative disease. He did not have a life-threatening illness. So when MAiD first became legal, you had to have a reasonably foreseeable death. And they hadn't specified a time. It wasn't that it had to be within a certain period of time, but it had to be reasonably foreseeable. So most of the cases were cancer. But this guy said, look, I mean, I'm suffering just as much as somebody who has cancer. Why can't I have access to this? And he made it a disability challenge. That's how he took that to the Quebec court, and he won. And after that, the rest of the provinces did not challenge that. It came through in the Canadian law. So usually if one province finds something, the rest don't want the expense and the challenge of going through the court cases. So they will then follow suit. But again, only because somebody else did first. So that started in March 2021. That's not that long ago. What changed then was that they took away the condition that you had to have a reasonably foreseeable death. That's a huge deal. That kind of opens the doors to an awful lot of patients. It used to be you had to have your request for MAiD had to have 2 witnesses. They reduced it to 1. That doesn't make a whole lot of difference. The witness has to be somebody who is not in your will, it has no impact on them, whether or not you die. So this is where we started what we call the 2-track system. So the track 1 patients are the ones who have a reasonably foreseeable death, and the track 2 patients do not. Those patients, the track 1 patients, there used to be a wait time of at least 10 days. They took that away, but the track 2 patients have to wait at least 90 days before they can have MAiD, 90 days from their first assessment. They also instituted what's called the waiver of final consent, and we'll discuss that a little later. Now, if you have somebody who's in track 2, so they have, I don't know, rheumatoid arthritis, and it's their pain that is causing them to request MAiD. If I go and assess them, I am not an expert in rheumatoid arthritis, and I certainly don't know whether they have had all of the appropriate care, whether or not more could be done for them. So if I'm one of those MAiD assessors, I need to go find a rheumatologist or 2, or a neurologist or a pain specialist, or all those things to review this case to ensure that everything has been done for this patient and explore all of the potential alternatives. Okay, so what are the criteria? Who is eligible for MAiD in Ontario? It is province by province. There are certain things that are consistent, but Ontario has its own rules. And since we are in Ontario, I only know these ones. So you have to be at least 18 years old. That might change, and that's going to be another challenge. You have to have capacity, and that's very difficult, right? So you have to have capacity at the time when you have your assessment. As we know, with people, for example, with dementia, they might be very clear in the morning and very confused in the evening. So if I were to assess them in the evening, I would have to say, no, they don't have capacity. But if I go the next morning and they're clear, then yes, I did an assessment at a time when they had capacity. Capacity has to, for example, they might not have capacity to deal with their finances. but they have capacity to deal with their health issues. So it's a capacity around making health decisions, which is important. They have to be eligible for healthcare in Ontario. We don't want MAiD tourism. We don't want people coming from places where it's illegal to come to Ontario for it. They have to be in an advanced state or irreversible decline. Probably every single word in that is hard to define. And two people might see it completely differently. Their request has to be voluntary. If it looks like somebody has been coerced, obviously that doesn't work. They must have given consent. And right now, their primary condition cannot be a mental illness. As you might know, they actually did approve, the federal government has said that we are to move forward with MAiD for mental illness. At first, it was supposed to become legal in March 2023. March 2022. They postponed it to March 2020. No, the other way around. 23, they postponed it to 24, and now they have postponed it to 2027 with the understanding that we're all a little bit freaked out that this is going to be a little bit too difficult. And for track 1, as I mentioned, a death has to be reasonably foreseeable. Track 2, they also have to be 18. They also have to be capable of making decisions. They have to be eligible for healthcare in Ontario. They have to have a grievous and irremediable condition, advanced state of decline. All of these things are very legally defined, but difficult. What's irreversible? What's irremediable? What's grievous? And these conditions in part are defined by the patient. So if the patient says that their suffering is intolerable, we have to accept that they think their suffering is intolerable. It's not up to us to decide if it is. And as I mentioned, death is not foreseeable. So what are the safeguards to make sure that we are doing this in an appropriate manner? So you have to have at least 2 independent assessors who agree that the patient is eligible. The 2 independent assessors shouldn't be working together. That's kind of impossible. So for example, in Guelph, we all know each other. We have dinner together. We're not completely independent, but when we are assessing a patient, we don't discuss our conclusions. We finish our reports and send them to each other in an attempt to remain independent. But it's, if you go to some small communities, they might only have 2 assessors or 1 or none. And sometimes the assessors have to be virtual. As I mentioned, we had to discuss the alternatives, including things like hospice, like palliative sedation, etc. Now, the final consent, and in terms of the waiver of final consent, which I mentioned briefly. So that's the other thing that changed. If you are a track 1 patient, in other words, you have a death which is reasonably foreseeable. Let's say you are dying of cancer and you have pain medications. It used to be the day that we show up with our medications to administer MAiD, you need to agree on that day. Yes, I still want this. Do you know what's about to happen? Yes, I'm going to give you these medications, and then what's going to happen? I'm going to die. Is that what you want? Yes, that's what I want. You have that witnessed, and that's the only way you could proceed. Some of these patients are in a lot of pain, which is why they want MAiD in the first place. And it could be that by the time you get to the date when they have decided that they want it, they have taken a lot. They've pushed that pain pump so much that they can no longer clearly answer that question. If they are a track 1 patient, they can sign a consent that says, if I am not able to consent on the day of the procedure, you can still go ahead. That means we've decided on a date. I have a few patients who are lined up for January, whatever, 10th comes along. If they're still competent, they're still fine. I talk to them. They say, no, let's defer. We can sign another waiver for a date farther on in the future. But let's say at this point, they or their spouse or their kids say, no, you know what? She's ready to go. She can't tell you yes, but she's ready to go. I will still administer MAiD. The caveat there is that if at the time that you show up, if they make nonverbal signs that they are no longer consenting, they push you away, they shake their heads, whatever, then you don't. And then it's over. They're never going to have MAiD. It's you go home and that's the end of that. Because you've said they've lost capacity. So once they've lost capacity, there's no going back. The safeguards for track 2 are similar, but as I mentioned, you need to make sure that you have consulted with people who have expertise in the condition. You need to talk to them about other alternatives. And again, that can be very challenging, especially in some of these diseases that are not well studied, treated, defined. There might not be a whole lot of alternatives, or there might be alternatives that aren't available in Canada. It might be challenging. They have to wait 90 days and they cannot sign a waiver of final consent. So we've already discussed that. So I mentioned this because a lot of respirology patients are interested in or request MAiD. You think of your patients with interstitial lung disease, it's a pretty horrible way to die. They are certainly eligible. They have a reasonably foreseeable death, even if you can't give a specific time frame, it doesn't matter, right? You don't need a specific time frame. You know that they have a fatal disease. If they request MAiD, they will be eligible, okay? And to be able to have MAiD, you need 2 assessors. Generally, the first assessor is the one who is also going to do the procedure. The second assessor simply has to assess whether the patient is eligible. If one of your patients requests MAiD, you can do that second assessment. Okay? You have everything you need to do that second assessment, and you don't need to be afraid. And that might make the situation a little smoother. There is something called the Clinician Aid C, which you can find online. It's a series of questions that you need to go through with the patient. Some of them are very odd, or they seem odd. They want to know if they identify as First Nations, if they identify as having any disability, if they received any disability support. There are all kinds of questions which appear to be more statistical. The government is trying to gather more information about who is getting MAiD, but you have to have completed that. That is part of the assessment. So you fill out that paperwork. It's a checkbox. You do a short narrative. Mr. So-and-so has had IPF for 10 years. He's gradually declining. He has become housebound. He no longer feels that his quality of life is acceptable. He has not been coerced. He has made a voluntary request. There are no dissenting opinions in his family. You don't even need a physical assessment, but you can throw that in if you want to. And you can say, yes, I find Mr. X eligible for MAiD. And then that goes to the first assessor. And from that point forward, if the first assessor has found that person eligible, they've now qualified. That doesn't mean they have to have it. That doesn't mean they ever will have it. Only a small percentage of the people who request MAiD, get information about MAiD, go through it. I have had many who have been dying of cancer. They make a request, I find them eligible, and they die before they get MAiD. I mean, generally they're dying. And so they don't necessarily make it there. I have one with COPD. She made the request, I think 6 months ago. She's nowhere close to wanting MAiD. She just kind of wanted to make sure that it was something that was available. Now, if she comes back in 5 years and says, I want MAiD now, my assessment from this year is no longer going to hold. So you need to reassess. But doing that assessment is not that complicated.
Sorry, Jack, what is the minimum time between I ask for MAiD and I get it?
It hasn't been defined, but most of us think that a time frame of about 6 months to a year is probably as much as we're willing to risk, because a lot can change in that time. So the law doesn't state.
So there's no minimum time?
No. There have been, not me, I'm new to this, so I'm by no means a MAiD expert. This is something that I have taken up as my retirement hobby. So it's certainly not, I haven't done a lot, but the people who have done a lot have sometimes assessed person in the morning and the next day. If they see that this person is in excruciating pain, they meet all the requirements and they want it done, then it happens. One of the problems is that the there are a lot of problems. One of them is finding the nurses. So there are a lot of nurses who have ethical objections, who don't want to do it. There are a lot of pharmacists who have ethical objections and don't want to do it. So you have to find a consenting pharmacist, a consenting nurse. The nurses in Guelph, I don't know what it's like here. This is part, they usually have a full-time job and they're doing this extra to help out. It's not, there's not enough volume to have it be somebody's job. So they come in the evenings or on weekends. So you're just trying to find a time that works for everyone. So what is going to happen? What's coming up? And what do we have to be ready for? So the idea of mental health as a sole condition is going to be a huge can of worms. And one of the, I mean, I know what it's like here. I know what it's like everywhere. You can't see a psychiatrist to save your life, literally. It's very difficult to have access to mental health care in general, and certainly to have adequate mental health care. So is it going to be that only the very wealthy will be able to access this because they've been able to pay for private psychotherapy? They've had all of the alternatives, they've had whatever needs to be done. So it's anything ranging from psychosis, schizophrenia, depression, PTSD. Mental health opens up so many things that are going to be so difficult to define. And what's happening now is that we have a lot of people who also have a mental health issue. That's life. So even though we are aware of that, if that is what is causing their suffering, then they are not eligible for MAiD. It's very difficult to distinguish. I mean, if you have cancer, you might get a little depressed, right? Is it the depression that is making you want MAiD, or is it the cancer? Are you depressed because you have cancer? Maybe you were depressed before. So teasing all this out is very, very challenging, actually. Advanced directives, oh my God. Even though we all kind of want this, I think, I don't know how it's going to work. It's going to be almost impossible. So the idea being, right now, dementia, you can have MAiD if you have dementia, so long as you are able to consent and as long as you have capacity to make healthcare decisions. So you have to be relatively early, obviously, in your dementia. Dementia is considered a neurodegenerative disorder and not a mental health disorder, which is why they qualify. So a lot of people will say, well, I don't want MAiD when I'm mildly demented. I want MAiD when I no longer recognize my family, or when I can't care for myself, or when I have to go to long-term care, etc. So those might be the situations where people want MAiD. So they want an advanced directive. They want to be able to write something down that says, when I don't recognize my children, when I don't know how to wipe my own bum, when whatever. But as you know, people are very bad at kind of forecasting what they will want by the time they get there. And also sometimes things that you thought were going to be intolerable, once you're there, you learn to live with it. And it's really not so bad after all. Plus, I mean, even now, even with these people who I'm seeing for cancer, for example, who you would think it's pretty clear, I want MAiD when they can't control my pain, or I want MAiD when I can no longer look after my grandkids. By the time it actually comes, that's something else that generally pushes them to say, let's go. It's not what they said at the beginning. So I had one sweet little old Austrian lady, and she had a cancer that had started in her cheek and then had spread, and it was making it very difficult for her to eat. And she said, when I can't eat my schnitzel, then it's time to go. And okay. And I saw her several times, actually. And the second time I saw her, I said, so how's the schnitzel? And she said, well, I have to cut it up in very small pieces, but I can still eat it. Okay. And the next time I saw her, the schnitzel had to go in the blender. And that was really kind of gross. But she didn't say all right away. It wasn't long thereafter, but I mean, so it was a very specific criteria. When I can't eat schnitzel, I don't usually get people who are that clear, but sometimes there is one thing that's the breaking point. The other thing that is going, I hope, coming, and I'm showing my hand here. Right now, a building such as this one that has Saint in front of the name won't do it. You cannot have MAiD in a building that has any kind of religious affiliation. In Guelph, for reasons that I don't understand, at our hospice, they don't allow MAiD. It's not a religious institution. It is just aid. And many hospices don't allow MAiD, which I find atrocious. But again, I'm just showing my beliefs here. So the challenge is being made in BC. There is a case that's going to court. And what they are saying to the hospitals is you are not a religious institution. Your name is Saint something. You're not providing religious services. You're providing healthcare, which is federally and provincially funded. You cannot claim that you are a religious institution. You're not a church. You have to provide abortion. You have to provide MAiD, whether or not that is going to happen. And again, as we know, you can say you have to provide these things, but that doesn't mean it happens. They can say, it's legal. Yeah, we allow it. But then you try to have it happen and it simply doesn't. So probably that is going to proceed within the next year or two. I don't know. These things take time. If it falls in BC, in other words, they say no religious exemption, the other provinces probably will follow suit because they don't want the expense. But what that's actually going to mean, we don't really know. But I hope what it means is that a hospital is a hospital is a hospital. A healthcare institution has to follow the laws of the land. MAiD is legal in Canada. You can't decide it's not legal in your building. That's not how the criminal code works. For the advanced directives, I don't know if you have followed this, they've made them legal in Quebec, right? Even though the federal government says we haven't changed the criminal code. At this time, it is still a criminal offense to provide MAiD to somebody with advanced directives, but we're not going to pursue that. So I don't know, if I were a doctor in Quebec, would I be willing to take a chance on being charged with murder, because that's basically what you're going to be charged with if you perform MAiD that's not legal. I'm not that brave. I'm not Morgenthaler. I'm not Kevorkian, and I'll do whatever's legal, but I'm not pushing the envelope. So where are we at? What is happening here? Now, these graphs are somewhat misleading because it starts at inception. It starts at 2016. So of course it starts at 0 and it's steep from then on because it didn't exist. It has not yet reached a plateau. It will. And I think we're probably approaching the plateau. It's usually at around 4% of deaths that are MAiD deaths. We're approaching we're at around 3%. So of course, right now it looks like that slippery slope, right? It looks like MAiD is going to continue until 100% of people die of MAiD. It's a very, very straight line. But if, that's not the way it's going to be. As you can see, track 1, 398 compared to 16 track 2. So there are much fewer track 2 MAiD provisions. The other thing is there is an option for patient administered, which we never use. I don't even discuss it, where you basically give the patient a lethal dose of barbiturates that they can take on their own at a time of their own choosing, instead of having IV. I don't see why in the world, when we have the IV available, you'd want that. The states in the US that allow MAiD, it's only oral. They do not have any state in the US that allows any form of IV drug administration. It is this, it's a lethal dose of barbiturates. So if you have ALS and you can't swallow, or you can't put pills in your mouth, it's not accessible to you. Somebody has to help you. So either you have a family member help you at their own risk, or it's basically not available to you. I know this is very small, but it essentially shows you that big part of the pie is cancer. So the vast majority of people who seek MAiD have cancer, but I did highlight that you do have 8% there that have respiratory conditions. I think if people knew about it, they're probably, or knew more about it. People are finding out more and more about it for sure. When I will say that as a working respirologist until a year ago, I didn't know anything. If patients would ask me about MAiD, I would not be able to give them any information. I knew nothing. And yet I had a lot of patients who would qualify and would probably be very interested in hearing more about it. So I do think it kind of behooves us to know a little bit about it. And to know that they are eligible, because we also get people who are referred who say, oh, my doctor told me I wasn't eligible, and that's not true. Because they don't necessarily even know the eligibility requirements, and they're changing. So if you don't know, please ask them to seek information from somebody who does know. Don't just tell them, no, you can't. Well, unless you disagree, which is a different issue. Quite a lot of neurodegenerative things like ALS, like MS, those are quite common as well. COPD qualifies. You know, you can have COPD as your sole diagnosis and you can qualify. You can have CHF and qualify. So again, it's a lot of our patients. This gives the number per health unit. I wish it gave the number per population, because this really doesn't tell you anything unless you know the size of those communities. But I will say that so Hamilton has 112 and Guelph has 99. I'm pretty sure Guelph is a lot smaller than Hamilton. So I'm not sure why that number is quite so low. Obviously, the biggest is Toronto, 407. That's not huge. That's a highway. But that's the biggest in Ontario, as well it should be. So there are areas, for example, around Guelph, there's a very large Mennonite area. We don't get a whole lot of MAiD referrals from the those kinds of communities. So I think it does depend on where you practice, and it does depend on how many MAiD assessors and providers you have in your area. I don't know if you've been following some of the controversies in the media, and we can certainly chat about it. But one of the things that people are trying to make you believe is that it's all disadvantaged poor people who are seeking MAiD to relieve their life's challenges. I would tell you that I think our concern is the opposite, is that it tends to be well-educated, well-informed, relatively affluent people who are seeking MAiD. It's people like me. It's people like you. It's people who it's a lot of people who have seen somebody die in a horrible way, who like, no, thank you. I don't want to go down that route. You don't see a lot of people, you know, who are really uneducated, looking for MAiD. What we do see in the paper sometimes is so-and-so couldn't find a subsidized housing, therefore they are choosing MAiD. Well, yeah, maybe they made a request for MAiD, but they're not going to be found eligible. So they make this sensational headline, but that's not the reality. The reality is you can't have MAiD because you have cockroaches in your apartment, or for food insecurity. I mean, it's a huge problem. Obviously, it's a huge problem, and I can understand that that's something that would make you struggle. But that wouldn't be considered an acceptable reason. Does that mean we can fix that problem? If I were to see somebody, I haven't yet, but if I were to see somebody whose main challenges in life are financial, what am I going to do? Like write them a check? How am I going to solve this person's problems? I can try to direct them towards some social services. I can get a social worker involved, but I can't fix that. I can't fix that. So to ask me to be able to treat the alternatives is completely absurd. The vast majority are white. So again, I think if anything, what we're seeing is that this is a little bit of a white privilege thing. It's not a disadvantaged situation. It's a situation where the upper segment of society, the richest segment of society, is having access. So don't believe what you read in the media. Just in terms of the total numbers, so they do this cumulative total. I don't know any other condition where you continue to add from day one, but since 2016, there have been 22,000 MAiD deaths in Ontario. these statistics are from September, so we are in December. We'll have those December statistics probably by February or so. But yes, so it is climbing a little bit, including that in the third quarter, there was a higher number than proportionally. Very few that actually invoke a waiver of final consent. Organ donation is an interesting option. It is an option. So if you're dying of ALS, for example, your organs are completely donatable. So that's difficult. Then you need to have the person come to the hospital to perform MAiD, have the transplant team on site ready to harvest organs. We have had it happen in Guelph. Guelph is actually very high in terms of the Trillium team's numbers. They're very transplant aware and try to make sure that anybody who has a potential for organ donation is at least considered. So that's something to keep in mind as well. Okay, and then we get into sort of the more prickly cases. Let me just, I started late, so I just don't want to be, I don't have, only a few more minutes. Is there anything in particular you would like me to, like, there's not a whole lot of time, so I'm just wondering if there's something that, yeah? Pardon? We have extra time. Oh, I'm going to go into overtime.
Go ahead.
No, go ahead. What's your question?
My question, two questions. First was, you mentioned about in terms of someone who does not have capacity anymore. But if they have predetermined that under certain circumstances, if this is not part of my quality of life, then I would want to proceed with it in terms of the advanced directives that you said. Does that supersede the issue of capacity at the time of administration? So that was my one question. And my second question is I'm personally involved in a case with someone who we filled out a section C and they're in stream 2, but within Hamilton, apparently there is a concern regarding the bandwidth manage
track 2
cases.
Yeah.
And I'm just wondering about what your experience
Yeah. Because I'm a newbie, I have not yet taken any track 2 patients. They are very difficult, very, very difficult. And the amount of paperwork involved is obscene. So it is quite demanding. So yeah, it is difficult to find somebody who is willing to take on, and most people, even if they do take on a track 2 patient, they'll take 1 or they'll take 2. They won't accept all comers because it's a ton of work, and sometimes you can't really solve this situation. Did you read the coroner's report recently? Okay. So there was a report that came out from not long ago from the coroner's office in Ontario, which did cause a lot of kerfuffle. One of the patients who died in track 2 had what he thought was post-COVID vaccination syndrome. That was his complaint. That's what he thought he had. And the doctor who assessed him, it spent a lot of time there were a gazillion consults of neurologists and this and that. And they never came up with kind of an alternative diagnosis. And in the end, allowed this to go ahead. The patient, and in fact, he was an organ donor. This patient did have MAiD. And then the coroner said there was nobody with expertise in post-COVID vaccination syndrome who was consulted. And I'm like, who is this said person? So how is one to consult with a person who doesn't exist? And then they did an autopsy on that particular gentleman and found absolutely nothing wrong with him. So that's concerning, right? So I wouldn't have touched that case with a 10-foot pole, and most people wouldn't. Does that make it the right thing to do? I don't know. That guy felt he had a legitimate beef, and he was well within his rights to request an assessment. So that's challenging. Your other question is exactly my next slide. So you gave me a very good segue, and this is about advanced directives. So what you are talking about is in fact advanced directives. And that's a little bit muddy too. What's the difference between waiver of final consent and advanced directives? So a waiver of final consent, I say January 10th is my day. Okay, I'm going to go that day, even if I'm confused. Not, I'm going to go one day in 10 years if I decide that it's time. Advanced directives means I don't right now feel like I want MAiD at all. I'm not anywhere close if this situation arises in the future. So it's kind of the same, but it's not the same, right? So you're talking about advanced directives. So this is a hypothetical case, but it's not so hypothetical. And in fact, this is a case that they brought to the MAiD conference in May. So here's this little old lady, Millie, who has an advance directive and who says, you know, when I'm not able to recognize my kids, when I don't know who I am, when I'm not able to look after myself, whatever, has a series of conditions that make that at that point she's going to want MAiD. And now she's living in a nursing home, and she's ticked all those boxes. She doesn't know her kids, she doesn't know who she is, she can't look after herself. She has fit the criteria that she herself had established. So here we walk in with our box. It's time for Millie to go, right? And Millie's sitting in the music room and she's tapping her foot and singing and laughing and having a grand old time with her friends at her nursing home. Am I going to sedate her and kill her? No, I'm not going to do that. And one of the issues that has come about is that almost every MAiD practitioner has said, I'm not going to do that, even if it's the right thing to do. That's what Millie said she wanted. So we are respecting Millie's wishes, right? But could you do that? Could you take a smiling, happy, singing person, shoot a little Versed in them and kill them? I can't do that. So even though, yes, and ethically speaking, it's the right thing to do. Because when Millie was able to consider her own health care, her own, what her desires, her wishes, that's what she requested. She's no longer that person. She no longer has that capacity. So, I mean, ethically, legally, you'd probably be well within your rights to do that. I personally could not. And I think it would seem that would be on the front page of the Globe. I think you drag this singing, foot tapping woman away. Like, so, but maybe her family says, look, you know, she absolutely did not want to be in this situation. This could last for 10 years, right? She's not dying. She's just demented. So it becomes very, and then, you know, maybe, as I said, maybe she didn't think that was any quality of life, but it doesn't look like she's suffering now. She looks quite happy. So who's going to decide whether she has an acceptable quality of life? It's not Millie anymore, because she can't speak for herself. So it's hugely problematic, but that's exactly what you're talking about. And I think most of us think we know, you know, yeah, I think if I can't look after myself, that's what I want. But, you know, or maybe say, would I want dialysis? Well, if I need dialysis because of I don't know, glomerulonephritis, and that's all that's wrong with me, sure. Okay. If I need dialysis because I'm dying of cancer and I have hypercalcemia, no, I don't want. So it's not the thing, it's the situation, it's the whole situation. And which is why the advanced directives are going to end up being, you know, War and Peace long. It'll be 2 tomes of if this, then that, and you'll have to draft it with somebody that helps you, like your family doctor, because they're not overburdened. So imagine this kind of, and it'll all have to be legal. So how do you actually draft this kind of a useful statement? Because as we know, most people's advanced directives are entirely useless, right? They come in with a thing that says, if I'm in a vegetative state with no chance of recovery, I want to die. Well, duh. I mean, I don't need an advanced directive to tell me that, but that's pretty much never what we're dealing with. We're never dealing with 0 chance of recovery. Yeah, so I already talked a little bit about the mental health cases. Now, with the media portrayal, it's making me a little sick to my stomach, to be honest, because the kinds of things that you see are really quite horrific, including from Sean Watley, who used to be the head of the OMA. So I would like to just tell you what my experience has been with these situations. So first of all, I go and I meet with these people, I chat with them, and we are having discussions that are more intimate and more profound than any I have had with anyone in my life on the first day we meet. Not with my family, not with my spouse, not with anyone. I'm sitting there asking them, well, what makes it worth living? What makes your life worth living? How are you going to know when you don't find it worth it anymore? Is religion important to you? And if they say yes, and I say, well, how do you feel about the fact that the church is in disagreement? We're having these political, religious, moral, ethical discussions. I'm there for about an hour usually. It's almost every time I get a hug on the way out, almost every time. And they are always, if I find them eligible, they're so relieved. They're visibly relaxed, right? Because they know that they have this as an option. And typically now they have bonded to me, as if it's not like I'm doing anything different from what another assessor would do. But after you've had this kind of conversation with people, it becomes, we're family practically. All right. And I have one woman who has metastatic breast cancer. She said, it's going to be you. It has to be you. You know, I was on vacation in November. She says, well, it's going to be before, it's going to be after, but it has to be you. Like, okay, this is a lot of responsibility. Like, what happens if something happens while I'm away? So it's profound. It is profound, it's moving, and it's beautiful, and it's peaceful. So the first case I was involved with, the daughter was in the room, and she said to her mother, you watched me take my first breath, I'll watch you take your last. I mean, we were all in tears. It's just so sweet. And they're there and they're holding their hands. And so you have these, I don't know if there's the horrifying truth behind MAiD, which is this Jordan Peterson interview. I couldn't watch it to the end because I was so angry. So first of all, they talk about medications that we don't use. They compare it to execution in the States, say that the way that the patients are dying is they're drowning, but that we paralyze them first so that we can't hear their complaints. Anyway, that's not how it is. We give them, you start with Versed. Okay, I don't know if you want to know, but the procedure is you start with Versed. They generally fall asleep. Then we give them lidocaine to freeze the vein. You have double IV access just in case you've lost an IV. And then we give them 1,000 milligrams of propofol. That's a lot of propofol. I don't know if you're using in the ICU, you don't give a bolus of 10 or you don't give 1,000. 1,000 is like 2 big syringes. So at that point, they are in a very, 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 very deep coma. We wait to ensure that they are in a very, 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 very deep coma, and then we give them rocuronium. Okay, so it takes at most 10 minutes. There is zero struggle, there's zero pain. For the family watching, it is very quiet. So what you read, what you see, it's just not true. They're not drowning to death. If you drown to death with propofol, a lot of people would wake up from their, knee surgeries in a lot of distress. That's just not what it is. So yes, is there a slippery slope? Yes, there is a slippery slope. We are expanding the criteria. That's true. And it is true that we have to be very careful about how we define who is allowed. And the problem is that some of that is subjective, right? So I might assess somebody and say no, and then the next person will say yes. And if we say that they are the ones who have to say whether their treatment is acceptable. For example, let's say you have a patient, one of your patients, one of my previous patients, who has one little nodule in their chest. Looks like it's probably maybe a malignancy, but we don't know, okay? And the patient says, no, I don't want anything done about it. I don't want a biopsy. I don't want anything. I don't want a bronchoscopy. I don't want anything. I think this is all of it is unacceptable to me. I want MAiD. Well, hang on. Do you have an irremediable condition? I'm not convinced of that. Might not even be a cancer. It might be a granuloma. So, but what it says in the protocols or in the even in the law is that It has to be that the treatments are acceptable to the patient. So if the patient says, well, that's not acceptable to me, I don't want a needle in it. Okay, it's not acceptable to you, but I don't think that that makes you eligible. But the next person might say, that person said it's not acceptable to them. I've had many, for example, who have had 2-3 courses of different chemotherapy. The oncologists want to offer them a next one, and they say that's enough. I say, I agree. The oncologist might say, no, they haven't exhausted the possible treatments. This might work. So it is difficult. It's very difficult. We're supposed to be able to consult with an ethicist. Apparently we have one we can consult with in Guelph. I've never met this person. Most ethicists in hospitals deal mostly with clinical trials, right? Not so much with these kinds of situations, but there are ethical parameters. You can go through an ethical discussion to decide. Yeah, and this is the other thing that I already talked about, where there are all these reports coming out in the media, in the Globe and Mail, that basically we're killing off the disadvantaged. One thing that happened, which is truly, truly abhorrent, in this CAMAP group, so the MAiD providers, we have a discussion forum. So because a lot of the times, especially in small communities, people don't have a lot of people to bounce ideas off of, to discuss cases with. This is a kiddo-wide group. And so people discuss, what do you think? Have you ever had this situation arise? And some people were concerned, like I mentioned before. I suspect this person wants MAiD because they don't have all of the disability supports that they could have. And maybe that's the issue. And have you been concerned about that? And other people have said, yes, I'm worried about that too. Well, somebody on that forum took all of the discussions that had taken place in this supposedly private space and gave them to the media. And the media ran with this and said, the doctors who are performing MAiD are worried that they are targeting the disadvantaged. That's not what happened. What happened was people were discussing these difficult cases. I mean, would you rather we not discuss it? Would you rather we just have no concern about whether there's equity or anyway? So that's what maybe you've been seeing this in the media, and it's truly sickening. It is a very biased, not at all what is happening. In my opinion, it's not what I see. I can't speak for every community, obviously, but the people who I see are the kindest, most empathetic, considered, thoughtful people I've ever met. You're not in it for the money because it does not pay well. These are not people who are going around randomly, providing MAiD to people willy-nilly without any concern about what they're doing. That's not what's happening. And I really don't want you to have that impression from what is out there. Jerry?
Jackie, thank you so much for this morning. There are a number of thoughts though. One of them at least is we hear from patients with chronic illnesses that we can't cure.
Yeah.
They don't want to be a burden to the family.
Yeah.
And the intent to have an absence of coercion. But this is very broad
Yes.
in some of our patients.
Yes.
So how do you handle that?
Well, it's very difficult, and I think you can never be entirely certain. One of the things is that you want to try to meet with the person alone without any family members present, in the hopes that they might share with you a little more honestly than they would if the kids were there, or the spouse or whoever they are worried that they are burdening. But yeah, that is an issue. And typically, if the person says that, like my schnitzel lady, she was very worried about being a burden to her son. Her son had quit his job. He had moved in with her in order to help look after her. And he said, no, I mean, I'm not, she's my mom. I'm perfectly fine to do this. This isn't a burden. And yet that was one of her concerns. I think her perception was different from what he manifested. But yeah, it's an issue. It's one of the reasons people want MAiD, and it's one of the reasons I would want MAiD. I wouldn't want to be living in one of my kids' basements like that. Any other comment?
More slides. Or-
No, I think that's it. That's the end.
There's definitely some stuff.
To think about, yeah. Oh, okay, I can't see the chat.
Yeah, so I'll bring up the chat. That was a fantastic talk. I have to some extent found some of the processes and policies to be somewhat challenging and at times opaque. So you've made things much clearer, which is fantastic. Let's see if there's any questions. There's a comment from Sophie saying at Hamilton General, it's usually 3 to 4 day process a week at most for those who are admitted.
Okay.
So that's helpful to know. Let's see if there's anyone with hands raised. So frustrating St. Joe's because they won't allow it here. Yes.
Saint. That's the magic word. You don't have to call it Joe's. Just call it Joe's.
But you've heard. So I think you know a point that comes up sometimes with trainees that are coming through is that we have patients. It's not uncommon for patients to come in here requesting MAiD.
Okay.
And we are as clear as possible that we can be very exuberant in our relief in our strategies that target relief of symptoms,
Right.
which borders on MAiD but is not MAiD.
Is not MAiD.
I think some of them have their own discomfort with the process and whether they'd be willing to be involved in it.
Yeah.
Some of it because of its complexities and some of it for their moral or religious
Yep.
reasons. And I think some people feel concerned that if they can compel a hospital, can they compel an individual to do something that is potentially outside the scope of practice?
I can answer that because that is very clear in the law that no individual can be compelled to participate in MAiD. So if you yourself have any moral or religious objections, you cannot be forced to participate. However, just like with abortion, not that it happens, if you go to your family doctor and you say you want MAiD and your family doctor is against it, they have to still provide you with the required information to lead you to somebody who can help you. And that is not happening. One of the big issues is that there's a very big issue between palliative care and MAiD. Not in Guelph, many of our palliative care physicians are MAiD providers, but in many places, it's almost that there's an animosity that the palliative care doctors say, if you provide good palliative care, you don't need MAiD, right? That MAiD is a failure of palliative care. I don't agree with that. I think, yeah, you could probably relieve somebody's pain, but it might be at the expense of having them completely comatose for an extended period of time, or to have so many side effects from your treatments. So I don't believe that. I think MAiD is an extension of palliative care, or it's a component. And we are supposed to let people know that it's available. That has also been a problem, in that some people feel like the doctor is suggesting it. So it's not that we're necessarily, or I guess it's in the way that you present it. But if a patient comes into you, and this is the way that some patients have reported it, whether it's what happened, I don't know. That they go see their doctor, they say, I don't know, I have this excruciating back pain, nothing has been done to help me. And the doctor says, well, then maybe you should consider MAiD. That's how the patient reports it, right? Maybe that is what happened. Maybe they said, I don't have anything left. I don't have any other options. I don't know what else to offer you. And maybe they did mention that MAiD is out there, but that some people feel like they are being coerced, that this is what they're being told is their only option. That obviously should never be the case. And one of the very important things when you're doing a MAiD assessment is that you have to make sure the patient knows they can withdraw their consent at any time. At any time during the whole process, including on the day of, if they're still awake and alert, haven't signed a waiver. If we walk in with the nurse and the bag with the propofol and the IV is started and they go, wait, change my mind, we go home. That's it. That's it. You can withdraw your consent up until we've given the Versed, and then you can't.
Have you ever had one of your, when you were the first assessor, has the second assessor ever said no? Or have you had it the other way around either?
Almost, but not quite. So I picked pretty easy cases because I'm a wuss and because I'm new to it, and I'm kind of gradually getting more comfortable. So most of the cases that I see, they're very clear-cut cancers, right? Or yeah. I had one patient, the second patient I ever did an assessment on, who he had advanced COPD and a lung mass that looked like cancer. I go, oh, this is my guy. I know, I got this. And I go in to see him, and he's lying in his bed, kind of fetal position, and he won't turn around to talk to me. And he won't, again, this is sort of the case I talked about. He won't let them biopsy this thing. It looks bad. It does look like a malignancy, but he says, I don't care. I don't want it. I just want to go. You're going to give me the needle and I'm going to go. And I said, well, it might not be cancer. No. I said, well, what about for the COPD part? Like, what puffers are you on? I'm not on any puffers. Well, maybe we could try a puffer. I don't want a puffer. Well, I don't think we've exhausted the possible treatment options here. So I left that going, this is not so clear cut at all. I don't even know that he has cancer. He's not accepting any treatment.
You do it the first or the second?
The second. I still have to find it. So that's the thing, is that both assessors have to find him eligible, but they don't necessarily have to agree on the track. A first assessor is responsible for identifying if it's a track 1 or a track 2. That patient, what ended up happening was that the first assessor put him on a little bit of pain meds and managed to get him on an antidepressant. And then he perked up and he got out of bed and he started accepting treatment. So then it became a lot easier. But I looked at this and I said, I think depression is the issue here. And I wasn't comfortable with it at all. So I thought, if this is what doing a MAiD assessment is like, I think I'm changing my mind. This is not clear. I like schnitzel. That was clear cut. But yeah, you don't always agree. I mean, that the good thing about knowing where you work and knowing your colleagues is that we kind of have a sense that we're all on the same page pretty much. So there's no kind of big ethical discussion. We might disagree about like little things, but not on the big things. For example, one discussion of the patients asked that the MAiD assessor not inform their family doctor that they were pursuing it. And I said, well, I don't think they're allowed to do that. Are they allowed to do that? I mean, the family doctor's in the circle of care. And they said, well, it's a privacy thing. You can't divulge it if the patient won't let you. And I said, well, I don't know. I don't know what that law is. So I actually called the CMPA the next day and I asked, I said, here's the situation. And they said, yeah, they're allowed to say, don't tell my family doctor, but then it's your job to try to understand why. And for example, if they think that the family doctor will judge them poorly, to say, well, the family doctor is obliged to continue to treat you, even if they don't agree.
Brought up something else.
Okay. There's lots of things. I could talk for 10 hours. Yeah. Yeah.
So Kalini and I had a patient with a rare disease, mismanaged by somebody for 3 or 4 years before we met. We worked with him for about 6
Was it my patient? Okay.
6 to 9 months. With the advent of new immunosuppressants, cocktail immunosuppressants, her illness came under control. She had destruction in her oropharynx, and we had a new ENT guy who was a whiz at fixing things that were broken, or busted, or degraded. And so the next thing we read was that she had died peacefully at home, surrounded by her family in the summer.
And you think it was MAiD?
It was.
Oh.
We asked.
Okay.
Afterwards.
Okay.
And her illness was now controlled. She had trouble, but it defeated every principle I ever heard about this. And whoever said that her problems that she was going to die of it, they were wrong, because she wasn't dying.
Well, yeah.
They didn't.
The
first version of death notes.
And yeah, so that case, that would have probably, that's challenging. If it's a track 2, which this one they might have wrongly made it a track 1, but if it's a track 2, you're supposed to go get all the consults from all the subspecialties, and you're supposed to, and then when you say that you're an irreversible decline, if the trajectory did this, that's not irreversible decline. So yeah, you're right. That should be not right now. And usually what we say, well, not me, because it hasn't happened to me, but my colleagues will say, you're not eligible yet. You might be eligible at some further date, but right now you're not eligible. But yeah, and that's part of the problem, is that those cases can torture you because you're not, it's very difficult. Yeah, sorry. Yeah. Oh,
we have Laura and then her.
Yes, yes. And the patients do that. So we have one guy who's like in his 20s who has post-concussion syndrome, who everybody says is not eligible, and he keeps asking for another assessment. And you say, well, how many times are you allowed? I mean, you're apparently there's no limit, but it's very annoying. Like, no, you can't just keep shopping for assessors because you don't like, can you just accept that you're not eligible?
Last question, Perry.
Jackie, where does the CPSO stand on this? So if.
In what regard?
If the patient requests this, then is the physician obliged to give them information? If they don't, then it can
Yes.
be launched.
Yes,
The physician.
yes. You are, so the question is, are you obliged, if the patient asks for information? Yes, even if you just refer them to the website, or refer them to Death with Dignity, Dying with Dignity, sorry. You have to at least direct them to find information somewhere. Yes.
So you don't have to.
Absolutely not. No, you could even say, you're allowed to say, I don't agree with this. But if you want more information, here it is. Absolutely.